All right. Well, thank you all for joining today. We're going to give our next in a series of updates to the transplant community entitled COVID-19 After Transplantation, the Omicron variant, vaccines, and monoclonal antibodies. We have a great group of speakers and panelists that are on today. Myself, Michael Eisen, I'm one of the transplant infectious disease attendings. This may be the first opportunity for some of you to meet Dr. Satish Nadig, who's the new division head for abdominal transplantation, and I'm going to turn it over to him in a second just to say a few words. Sejal Tana, who's one of my partners in Transplant ID, John Flaherty, transplant nephrology, Daniela Ladner, transplant surgery, Dan Ganger, transplant hepatology, Juan Carlos Caicedo, transplant surgery, and Shelley Sandana, the lead post-transplant nurse. So what we hope to do over the next hour or so is to first let Dr. Nadig do a little introduction. Then I'll give a brief summary of where we are and where we're going and what our available therapies are. And then we'll switch over to Q&As to answer your questions. I would encourage everyone to go into the Q&A tab and put questions in as they come up, and we'll go through those and answer them over the course of the presentation. So Satish, did you want to say a few words to welcome people?
Yeah, I'd love to. Yeah, thanks, Mike. As Dr. Eisen pointed out, we're looking forward to educating, updating, and just discussing what the new variant brings us and what the COVID world is now bringing us. I'm sorry that we are continuing to have this conversation, but what gives me comfort is that we're surrounded here at Northwestern by a group of leaders that are not only leaders here at Northwestern, but are national and international leaders, not only in transplantation, but also in the infectious diseases that surround transplantation. This webinar is powered by Northwestern, but the information is applicable to all patients that are dealing with these types of issues post-transplantation. Lots of questions out there, and sometimes we'll end with probably more questions than answers. But rest assured that the group that Dr. Eisen has put together are global experts on not only COVID-19 and how it affects transplantation and transplant recipients, but the infectious diseases that surround transplantation, led by Dr. Eisen. Thanks, Mike, and looking forward to a great webinar.
Thank you so much. So let's move on and start with the presentation. So for those of you that have seen me give these presentations, I do try to do kind of a standard way of looking at this, and the first is to start globally and work our way down here to Illinois and give you an update of where we are. Then we'll talk a little bit about the variants and then how we're going to tackle all of these different things moving forward. So globally, if you look, Europe is kind of this dark purple. These are the highest rates of COVID-19. Some of the Eastern European countries like Germany and Austria really are having incredibly high rates. For Germany, they've had more new positives and hospitalizations than at any time point during the pandemic. And for all of these areas, this is all Delta. This isn't, Omicron has been detected, but is not the main driver of illness. As you'll see in a few minutes, the United States is definitely heating up, particularly in the northern parts of the state. Southern Africa, where Omicron really started, is really causing a huge amount of disease in that area, and we'll talk about that in a second. Looking at here in the United States, we have seen a huge change in where COVID-19 cases are. We have in the summer, we had the South, particularly Florida and the Gulf Coast states, really having the brunt of clinical disease that moved to some of the kind of central states as we moved out of the summer. And now that we've moved into the winter months where the northern parts of the United States have started to get colder, we're seeing really high numbers of cases. The real challenge has been that some areas like Ohio, Indiana, Michigan, Pennsylvania are seeing incredibly high rates.
Hold on.
And starting to see the.
You're still going on my computer.
I think someone needs to be muted. Sorry. Seeing very high rates of COVID-19. We're also important to recognize that while we've done a great job, particularly in older adults, in getting the country vaccinated, we still, in all age groups, only have about 61% vaccinated. And you can see from this map where darker green are areas with higher rates of vaccination, we still have huge swaths of the middle of the country that have relatively low vaccine uptake. And even in a state like Illinois, the further south you go, the less likely you are to see the vaccine rates being relatively high. Keying in on what's going on here in Illinois, again, kind of aligning with where vaccine rates are lower. We're seeing an increase in rates of COVID-19. Thankfully, while the numbers are going up, we still have lower rates of infection here in the greater Chicagoland area. In terms, though, of where we are, you can see in the red, these are new case reports, and we're just seeing the number of new cases going up very rapidly. Likewise, and because this lags by a week or two, rates of hospitalization are going up. And while we haven't seen the rate of deaths increase to the extent as we likely will, we are still a little early on in the peak of cases here in Illinois. And this is important. Everyone's been talking and focusing on Omicron, but we have Delta here, and that's what's the main driver of what is going on. And so we still need to focus, as we'll talk about, on getting boosted, getting our vaccines if we're unvaccinated, and doing the things that we can do, such as wearing a mask and maintaining distance to keep everyone safe. There's been a lot of talk about the Omicron variant, and I thought what would be helpful is to both graphically look at this and compare it to the Delta variant, the virus that we're seeing predominantly in the United States. And to look at this figure, this is the part of the protein that binds to the receptor that causes the infection. Anything that's yellow or is a mutation, and anything is gray is what they call a deletion, where part of the virus or part of the protein has been removed from it by the virus. And just looking, you don't need to be a scientist to realize there's a lot of yellow in the Omicron variant. In fact, there's about 30 mutations and deletions in the key areas of the virus, compared to just a handful of changes that we saw with the Delta variant. We're seeing an increased risk of infections and reduced protection from 2 doses of vaccine with the Omicron variant. What is important, and I'll show you some slides, is that while this is still only causing very few cases here in the greater Illinois area, looking at what's happening in other parts of the world is that the proportion of cases caused by Omicron increases very quickly, and I suspect we'll see that here in the United States. Looking first at what goes on when the virus comes into the community, really you can see 2 bits of data. The strongest data and the majority of the data that I'll be presenting is from the United Kingdom. They have a great system of looking at the data. And what you can see is this purple line here, this light purple line that comes up, is the Delta variant. And the reason why this is important is it took about 100 days before it became the dominant virus in the community. It had a relatively gentle slope in the way that it came in, and so you had a period of time where you had multiple viruses circulating before Delta became the main virus. During this time, you saw increasing numbers of cases, increasing numbers of hospitalization, but it took some time. The green is the Omicron variant in the UK, and you can see a much more pattern where the number of cases is going up very, very quickly, and it won't take it very long for it to overtake the Delta variant in the UK. They're predicting somewhere around 20 to 30 days before it's the dominant variant in the United Kingdom. And so this really will likely be mirrored here in the United States, although we're a little bit behind the UK. Similarly, in South Africa, which is shown by this squiggle plot here, you see this red bar coming up very quickly. That's the district where Omicron was first discovered, and you can see the rates of new cases really just skyrocketed when the virus came in. Now, why is that? In part because you see more secondary infections for every infected patient with Omicron than you see with Delta. Compared to the Delta variant, if you have one patient with Delta infected, you're going to see about 2.5 patients infected with the Omicron. So you're going to see 2 to 3 times more patients getting sick when they come in contact with someone that has the Omicron variant. And so once this comes to Chicago and the area, we're going to see the spread of the virus relatively quickly, as we've seen in other parts of the world. The second challenge is that if we look at the vaccine efficacy, so we saw that with 2 doses at around 6 months, vaccine efficacy for the Pfizer vaccine against the Delta variant had declined to somewhere around between 60 and 70%. But when you got that third booster dose, we really brought that back up to about 95% protection against getting infected. With the Omicron variant, and this is data again coming from the United Kingdom, this is actual protection against infection, not just neutralizing antibodies, but that you can see that with 2 patients that had only gotten 2 doses of the Pfizer vaccine, they had about a 34% vaccine efficacy. So only about 34% of exposed people were prevented from getting an infection. Once you got that third booster dose, that took you up to about 75%. But again, it's not quite up to where we would like it to be. Again, hinting that this is going to have more breakthrough infections and that it's going to be especially important to get that third dose. And what's problematic is if you look at how things are going here in the United States, only about half of eligible patients as of just a few weeks ago have gotten that booster dose. And so I think this is a great opportunity for you to think about yourself and your family members to say, have you gotten the booster dose? And if not, now's the time to get it to give you the most protection. Additionally, we've seen that there's a shorter incubation period, so the time between when you get exposed and you start getting sick. For the Delta and prior variants, it was around day 5 to 7. With the Omicron variant, it's around day 2 to 3. So once you're exposed, you tend to get sick much sooner. There have been documented transmissions of the Omicron variant among fully vaccinated and even boosted healthy individuals. These are rare, but they have occurred. When they do, they typically have been associated with being indoors without masks as a major risk factor. So again, masking can reduce that risk significantly. The other challenge is a benefit as well. If you're fully vaccinated, if you get a breakthrough infection, most of the time the symptoms are relatively mild, but that's a challenge because it may be less of a trigger for you to worry about potentially transmitting disease on to these patients. The other signal that we're starting to get is the rapid antigen tests, which have been really very helpful for us in identifying cases in patients without having to come to the hospital, are having some decrease in sensitivity. And so if you are worried about being sick and that you may have COVID-19 and you do one of these rapid antigen tests and it's negative, it's still important to reach out to the transplant center and see if we can get one of the PCR tests to see if you're infected or not. We also are finding that the Omicron variant has lost activity by some of the monoclonal antibodies, and importantly, the ones that we've been using very frequently. the bamlanivimab etesevimab, which is what we used earlier and are starting to use again, as well as the Regeneron Regen-CoV monoclonal antibody combination, appears not to have retained activity against the Omicron. Thankfully, we do have a drug called sotorivimab, which we haven't been using very much here, but we'll be ordering more and leading into as the Omicron variant becomes more prevalent. We're talking a little bit about the Evershield. There is some reduction of its activity, but it still seems to hold up and protect people from the Omicron variant to an extent. The oral therapies and all the therapies we've been using in the hospital still retain their activity and should be useful if someone gets sick enough to get hospitalized. So now that we've heard a little bit about the virus, let's pivot and talk briefly about the vaccines. There's been a lot of data that's come out. There's been a change in recommendation for booster doses overall, and we want to just clear up the recommendations in the next couple of slides. I think it's important to recognize that there are two fundamental benefits of getting vaccinated. The first is that you can create antibodies. This is the one that most people focus on. These antibodies help prevent you from getting infected in the first place. But sometimes those antibodies don't bind well to the virus or are too low of a number to protect you from infection, and you can still get infected. The vaccines also produce a cellular immune response, and that helps clear the virus out of your body much more quickly. And this is in part why we're seeing milder disease in patients that are vaccinated. And in fact, this is the reason why even if you get a breakthrough infection and you're vaccinated, you're less likely to be hospitalized and you're less likely to become severely ill or even die from COVID-19 because of this cellular response. And importantly, even though transplant patients have a reduced ability to produce antibodies, the majority of patients, particularly with 3 doses, generate excellent cellular responses that should help protect them against severe disease. So based on some of the data that has come out over time, it's been quite clear that the guidance is now recommending that all patients that had gotten a Moderna or Pfizer vaccine should get a 3rd dose at least 28 days after their last dose. So if you just started getting vaccinated recently, you do need to wait 28 days after your 2nd dose before you get that 3rd dose. But if you've had the 2 doses of vaccine at any time point that's 28 days or more in the past, you should go and get the 3rd dose of Moderna or Pfizer. We recommend that you optimally get the same vaccine for that 3rd dose, although you can get any vaccine that you would prefer. So again, this is a time for you to look at yourself and say, have I gotten my 3rd dose? And if not, schedule that appointment right away. The second issue is patients that got J&J. Recently, it was recommended that everyone, including our immunocompromised patients, get a 2nd dose of the J&J vaccine as long as it's 2 months after the prior J&J. They can get any vaccine. We recommend for our transplant patients that they get one of the mRNA vaccines, Moderna or Pfizer, because they just get a much higher antibody response. And then lastly, while the 3rd dose doesn't count as a booster for these patients, it is possible to get a 4th dose for our transplant patients 6 months after the 3rd dose of vaccine. And this may be important to help protect us as we see increased circulation for Omicron. We are not recommending the 4th dose prior to that 6-month period after the 3rd dose. It is important to recognize that even with the 3rd dose, about 45% of patients still won't have sufficient antibodies to protect from infection. And as a result, we aren't going to be checking antibodies because it's still not something that we're recommending, but that we recommend all of our transplant patients continue wearing a mask whenever they're in any public indoor space, continue social distancing, and continue minimizing your high-risk exposure, even if you've gotten that 3rd dose. Use extra caution as rates are increasing, which they are now. So for those people that prefer graphics instead of text, this is a great graphic that just really helps show you what you should plan to do with your vaccines. If you got Moderna or Pfizer, you want to get a second dose about 28 or 21 days after the first dose. And then as long as it's been greater than a month, you want to get a third dose of the same vaccine. If you got the J&J 2 months after the first dose, you should get a second booster dose of either one of the mRNA vaccines, Pfizer or Moderna, or a second dose of the J&J. We've been very lucky to have a range of monoclonal antibodies, and we've talked about these in the past. These are very effective when we give them to patients that are very early after their infection, as it helps reduce the risk very significantly of needing additional medical care or hospitalization. In fact, there's about an 80% reduction in the risk of these complications. Over the last couple of months, there have been some data that have come forward to look at these drugs in preventing infections either around the time of exposure or just prior to exposure in high-risk settings. And in fact, in both cases, there's been about an 80% reduction in the risk of these therapies. REGEN-COV has been authorized for this post-exposure prophylaxis. Unfortunately, because of capacity and drug availability, we have not been able to give this post-exposure prophylaxis at Northwestern. If you do get exposed, we would still recommend you contact the transplant team so that we can arrange for testing for you. And if you test positive, then we will give you the therapy. Unfortunately, the doses of REGEN-COV in the state of Illinois are getting lower and lower, and this is part of the reason why we've added back the BAM-EDI as a backbone of our therapy. In addition, our ability to give patients drug, the monoclonal antibody after exposure, has become quite challenging because the numbers have gone up above what we have capacity to infuse. So we just don't have drug or capacity to give post-exposure prophylaxis. The latest development is the AstraZeneca compound called Evusheld, which is a combination of tixagevimab and kilgrevimab, which are two monoclonal antibodies that help protect patients from getting sick. They did a study in generally healthy but higher risk exposed patients where they got a dose of this therapy or placebo, sugar water, and looked at what happened to these patients over time. There was a significant reduction in the incidence of COVID-19, down from about 3.1% to 0.8% of patients with PCR positive, as well as a reduction in symptomatic COVID-19 from 1% to 0.2%. So really, again, about that 77% reduction in the risk of developing COVID-19 in patients that have gotten this drug, Evusheld. This was authorized last week, and supplies are just starting to make their way out to the states. The challenge, and part of the reason why we're talking about this today, is that the supply does not, and for the near future will not, meet the demand. In the United States, there are around 5 to 8 million immunocompromised patients that are at risk for inadequate responses to vaccines. In the first 2 weeks since authorization, it's expected that there will be 50,000 doses distributed throughout the United States. And about every 2 weeks, another 50,000 doses will be distributed. The challenge is for each of those doses, there'll be about 100 immunocompromised patients that will be eligible for one individual dose. And so as a result of this mismatch between supply and demand, there will be allocation limited by the government to just selected transplant centers, and those centers are developing a tiered prioritization plan. For us at Northwestern, the Evusheld will be given in the various clinics that care for the immunocompromised patients. And we have to remember there are more than just transplant patients here at Northwestern. We have patients that have cancer, have undergone stem cell transplant and chemotherapy. We have patients that have rheumatologic conditions getting medicines, all of which put these patients to a position where their ability to respond to vaccines are reduced. The prioritization is given to patients who, due to the medications that they've been treated for their underlying condition, are unable to respond to the vaccine at all. And these are predominantly things that affect the B cells of the patients. This will all be done within the clinic. You do not need to call or request the monoclonal antibodies, and calling or sending a MyChart message will not increase your priority on the list. Patients will be called by the clinic when there is drug available and allocated to the individual patient. So when you get that a call or MyChart invitation, that's your chance to get access to the drug. It's going to take us a while before we can get through all of our patients to give them eligibility. And so I know it's frustrating, but it's something that we need to have patience about. Lastly, I wanted to talk briefly about two pills that you've been hearing about. The first, which was reviewed and is pending authorization by FDA, is a pill called molnupiravir. It has to be given very early after onset of symptoms within 5 days. It damages the virus in such a way that the virus can no longer replicate. It should be safe to give in transplant patients, although they weren't enrolled in the studies that have been completed to date. It really doesn't interact in any way significantly for our transplant medications. But it was effective at reducing hospitalization, but only resulted in about a 30% reduction in risk of hospitalization. So for most of us, we'll still be leaning on the monoclonal antibodies for patients such as yourself to help prevent the progression of the disease. For some patients, we may be adding the oral therapy to the monoclonal antibody as well. The second drug that you've been hearing a lot about is the Pfizer drug Paxlovid, or the PF07321332, that's in combination with ritonavir. This is what's called a protease inhibitor, which just basically blocks the enzyme that helps digest part of the SARS-CoV-2 and prevents it from replicating. The challenge with this combination is it has significant drug-drug interactions, meaning that we can't safely give it to most transplant patients. And I don't think this is going to be a drug that we use very frequently in our transplant patients. Some patients very selectively may get this, but because of that drug interaction, it's going to be quite a challenge. So kind of taking us home, what are our key recommendations? I don't know, this is, I think, a little, the first line is wrong, but let's go to the vaccines are incredibly effective in preventing infections, hospitalization, and death. Solid organ transplant recipients should get a third dose of the mRNA vaccines. Close contacts should get their COVID-19 vaccine and booster, and all SOT recipients and close contacts should get their flu vaccine. It's important to continue to wear your mask, socially distance, and avoid high-risk settings, even if you've gotten the third dose. And if you do get sick, call the transplant team immediately, as you may benefit from monoclonal antibodies. And it's important to remember, vaccine is not the only solution. We need to really add a bunch of things together to help maximally protect you. That includes keeping people that are sick away from you, wearing a mask whenever you're in a public location, limit your exposure to crowds, continue focusing on hand hygiene, and if, God forbid, you do get sick, give us a call quickly. So with that, I'm going to end here, and we'll switch over to the Q&A, and I'll take a look at our questions that are popping up.
I've been trying to answer a lot of them, Dr. Eisen, and maybe I'll just highlight a few that have come up repeatedly that we can address again, just as a reminder. The most common one has been, I've had my 3 doses. Should I get a 4th dose, and how do I decide when and how? You mentioned at least 6 months after the 3rd dose, but is that a recommendation for everybody, or should they be getting antibody tested to decide who needs a 4th dose?
Sejal, do you want to take that? Oh, Sejal's on mute.
You're on mute, Sejal. Now we got you. Now we got you.
Sorry. There's really no role for the antibody testing. If you're an immunocompromised host, go ahead and get that 4th dose 6 months after your 3rd additional dose.
Let me just clarify that. There certainly is going to eventually, we hope, be a role for antibody testing. So for hepatitis B, for MMR, we can check and see if you have adequate protection. That hasn't been established yet for COVID, and I think that's important to point out because we need to know what a protective level is with an assay that is reliable, and that hasn't been developed yet. We're hoping it does soon. So it's not that you can't measure it, it's just we don't know what a safe protective level is yet. Is that a fair thing to say, Dr. Tana?
Yeah, I think my biggest concern is people having a detectable antibody and getting a false sense of reassurance that they'll be protected and be able to go into large crowds or maybe unsafe places where they can be exposed to COVID and eventually get really sick.
Correct, but we are hoping and we are anticipating that eventually we will have an assay where we can measure antibodies to COVID-19 and try to determine at a level that we think is protective. And that is coming. It's just not here yet. Just to be clear. And even if you have protective antibodies, don't go to a rave without a mask on, is what you're saying.
Yes, please.
Okay. All right.
I think the other thing that we have to keep in mind with these levels is, as we've seen, these levels change over time. And so just because you have a protective level today doesn't mean a month from now or 3 months from now it's going to be protective. And so this is again why, yes, we could do all kinds of antibody testing, but I think we have to, and we'll learn over time, who we need to worry about, who we don't, and other ways to protect our transplant patients.
Certainly some people who have had antibody testing that have no antibody, that would be someone who should try to prioritize at the right timing to get a 4th dose. Would you say that's a fair statement?
I think everybody should get that 4th dose. If I was eligible, absolutely would get in line for that.
Another comment and question that's come up is, what about holiday parties? What about gatherings over the holidays? What is the safest way to do that? I'll throw it out to Dr. Eisen-Lateral, to anybody if they want. I can try to answer too.
Yeah, why don't we see what Dr. Ganger has to say first?
Yeah, I would say that what I heard is that we should probably, for people who are mingling with others or traveling, not to wear the cloth masks. I would say for our patients, they should probably wear the K95 or N95 when they travel or when they are amongst a lot of people. I think we have to be extra careful. That should not, even if you are vaccinated, you should not let the guard down. And in particular, if you are also amongst kids, that probably will, Omicron will probably fly amongst the kids in particular because most of them are still not vaccinated.
And then I'll turn this question over to Shelley. Do you need a prescription or a call to the coordinators to get additional doses of vaccine?
No prescription needed, as long as you meet the criteria to get your additional dose. You can call your local pharmacy. Usually they're all walk-in. Walgreens and CVS are usually walk-ins now, but give them a call to see if an appointment is needed, and you should be able to get in within a few days.
And then we'll give you kind of a similar chance to answer a similar question, John. I want to go home for the holidays. What should I do?
Yeah, so a couple things. I mean, what I tell a lot of my patients, I'll say to everybody, is we've learned the ground rules of how this virus operates. It spreads through the air. It spreads in poorly ventilated places where a lot of people are talking and eating and doing things like that. So avoid those places is number one. So being outdoors, being in well-ventilated spaces are safer places to be. The quality of masks, as Dr. Ganger mentioned, matters. Having a better filter to keep out the virus is important. And then the other thing we have still, at least for now, is that rapid antigen testing still works very well, except for, we think as Omicron spreads, it may be less effective. But for Delta variant, which is the predominant variant in the US, those tests are still working. So for now, what I'm saying is if you're going to gather with people the day of the gathering, when you get there, everyone can do a rapid test to get that other level of protection. And then, of course, if you know people are unvaccinated, they're at high risk for harboring and spreading the virus. And so you need to be extra careful around family or friends who are unvaccinated, and particularly keeping a good mask on or being in a well-ventilated space is the safest place to be. It's harder in the winter, which is why when Dr. Eisen showed that picture of the US, it's where people are indoors. When it's hot in the summer in the South, everyone's in the air conditioning. When it's cold in the winter in the North, everyone's inside in the heat, and that's when the virus spreads particularly well. So just understand where you're at risk and try to reduce your exposure to those events.
I think the other thing that's helpful is to take a look and see where you're going. I mean, it's very easy because you watch the news and you see them saying we've got this many COVID cases and whatnot. But there's lots of resources that are available to you. Your favorite newspaper, particularly some of the national ones, have great resources that show you what the rates are in different areas. And I think the two things that I always think about is when we travel, whether it's to see family or friends, we oftentimes let our guard down. It's just what you do. You feel comfortable around your family and your friends. And what you have to recognize is that there's differential risks in different parts of the country. And what the rate of COVID is in the area, what the degree of wearing masks are, will be very different depending on where you go in the country. And so that may be a part of your thought process. Likewise, I think this is a great time for you to start talking with your family that are going to be there, making sure that everyone's gotten that booster dose if they're eligible for it. If they have young kids, make sure that they've gotten their first or second dose of their vaccine to help protect them. Because I think that's really important to get the biggest ring of protection around yourself.
Can I add something? For recently transplanted patients, very recent, still a visit to our clinic should be considered safer than not coming to the clinic. We are all vaccinated, we are wearing masks, and it is much better for us to see the patient recently transplanted than do telemedicine. We will accommodate you, but not if you are 1 month after transplant.
So there's actually, I think it's a comment, but also I think a reality, and I'll send this to Dr. Nadig. So patients were very frustrated living in a bubble, and they for 20 months. I'm sure I'm not the only one who's frustrated with the wait and see approach and avoid places. What can we do to help protect ourselves when we think about things that may be higher risk, like going out to dinner with friends?
Yeah, I mean, I think just to reiterate what everybody says, the shackles of what people are going through on being on immunosuppression and being stuck in their homes are not lost on us. This has caused a big mental component. COVID has done more than just affect our loved ones and affected our respiratory and our health in general. It's affected our mental health as well. And so we do understand that, but it's not going to get better by ignoring it. And unfortunately, the only way that this gets better is that we get vaccinated and we mask and we social distance and we use our common sense. And one thing that we haven't added and we haven't talked about much is hand sanitizing as well, especially during the holiday period. I want to reiterate some of the things that Dr. Ganger said about being around our kids. The first thing we want to do is hug them and cuddle with them and all of the things that we do in the holiday period. But if you're immunocompromised, you're in a different boat, and you got a second lease on life with the organ, and we have a duty to protect the organ and protect ourselves in a very different way than the general population. So we have to use a little extra common sense and know that if we band together and do this, then we can get through these tough times together, because it's taken a toll on the healthcare providers and it's taken a toll on the patients, and it's not lost on us. So what can you do? You can do all the things we've talked about. Use the mask, social distance, and get vaccinated.
Perfect. Thank you.
Dr. Eisen, maybe could I suggest a question? Because I think there's a lot of interest in the preventive therapy with the antibodies, and much like the early days of vaccine, there's a bit of a limited supply, and so maybe we could touch on how we plan to roll that out here in our clinic. We've tried to do it in a way that we're going to try to get the doses to the people we think are at the highest risk first, and maybe a little more clarity on that. It's hard to just say wait for a phone call or a message. That's hard for anyone to do, and so maybe we could give a little more direction about how we're planning to do that.
Sure. So we have a tiered structure that we're going to use. The plan is to go from tier 1 down to the next tier and so forth. The first tier that we're looking at are going to be patients that are over 75. They will need to have gotten at least their vaccine. This is not a replacement of vaccination. This is something that's a supplement to vaccination. We will also be in that tier giving it to patients that have received a medicine called rituximab or similar medications that prevent the B cells from making an antibody response and may reduce the ability for T cells, those other protective cells, from forming, as well as people that are on belatacet, because this drug really does decrease the ability to respond to the vaccine, both from a humoral and cellular response. Then as we move down the tiers, we're going to start with the patients within the first 6 months after transplant, initially focusing on older patients, then working our way down to patients that are 6 to 12 months out, again, working from oldest to youngest. And the reason why we went with this approach is it focused on the patients that are most likely to have a poor response and at highest risk for having something bad happen to them if they get sick. We also have to keep in mind, we're not the only group that are competing in some regards for the limited supply of drugs. We have a huge number of patients that are oncology or cancer patients, a smaller population of patients that are on medicines to prevent connective tissue disease. And so these people are also eligible for the vaccine and may be getting, at least initially, some of the medication as well. So it is, while we have a plan, it's going to be one that takes a while before we get through all of the patients that would be eligible. There's a couple of questions kind of on the same theme, and I'll ask Dr. Tana to talk about this. What would you do if you're either have an unvaccinated child at home or you're going to be visiting with someone with an unvaccinated child?
So if your child is above the age of 5, they are eligible for the vaccine, and you should talk to the school or the pediatrician about trying to get those vaccinations done as soon as possible. If you do have an unvaccinated child or somebody who's too young to be eligible, I think it's hard. We're going into our second or third Christmas now doing this. I think I would make sure that they don't have any symptoms at all if you're planning on still going. And then I would also utilize not just the rapid test, but actually see if your friend or family member would be willing to do a PCR test on the child as soon as, like, close to the gathering as possible that you're going to see them. There is going to still be some level of risk, but I think you can mitigate it and bring it down a bit.
And then I'm going to also send you, because there's a couple of questions about monoclonal antibodies and other therapies. There's someone that's a heart transplant patient that, so if he gets sick, what should he do, and what treatments would he be eligible for?
Yeah, so if you have symptoms, please get tested right away. If you test positive for COVID or the flu, we've seen people get co-infected with both, call your transplant coordinator as soon as possible. Helpful details for us are your symptoms, when the symptoms began, and when you tested positive. The coordinators will reach out to one of us and we'll go over the monoclonal antibody, the Regeneron, to see if you're eligible and if you're interested. That then goes to the overall system and they'll see if you're eligible, and if there's enough supply, they'll reach out to you and schedule you for that. Even if you are not in the area, you can still call us and we can try to help set you up wherever you are. And obviously, if you're having shortness of breath or difficulty breathing, we might direct you to the ER so you can get more urgent attention, oxygen therapy.
Perfect. And then the next question, I'm going to start with Dr. Ganger, and then we'll go to Dr. Friedwald, and then maybe finish with Shelley. So I've been able to work from home, is what this person is asking, but the work is telling me I need to start coming into the office at least a couple days a week. There's been at least one case among my coworkers that have come back. What should I do?
Yeah, I think I answered that personally, but what I said is that, like I said, for the plane, right, to wear a high quality mask, and at least in the office, your managers should allow you to be sitting at a meeting at safe distance. I think that's the only thing I can say. It's obviously not ideal, but I would be cautious that way.
John?
Yeah, I'll say again, I mean, one of the things we've learned is how the virus spreads. And so once we know that and you understand the ground rules, as I call it, you can do everything you can to be in a place where you're unlikely to encounter the virus. The most dangerous places are indoor places that are poorly ventilated. So leaving office doors open, having a window open if possible, wearing a good high quality mask if you're going to be around people is one of your best protections, a good high quality mask. So some people say it spreads like smoke, but if you think about something hanging in the air and you don't want to breathe it in, the better quality and better mask you have is one way, and keeping ventilation is the other way to reduce that risk, and being further away from people if possible. So there are ways to do it safely, we think. Eye protection is another one. And so those are ways you can reduce your risk. But again, not gathering for long periods of time in closed spaces. And the highest risk places we know where people have the mask off, eating, talking, bars and restaurants indoors that are poorly ventilated are where all these super spreader events are happening. And so limiting your exposure to that, eating outdoors if you want to, and we all want to go to restaurants, but if you can go to one outdoors, and that's why it's hard in the winter time here. But some people ask, where can I go on vacation? Someplace warm where you can be outside. Absolutely. Take us with you. But those are, and I'm not kidding, actually, being outside, hiking, those are safe activities. And so that's the way to do this and get our mental health back in shape, because we all need some of this. And so again, knowing the ground rules is one way to safely start to navigate this.
Shelley, any other thoughts?
Yeah, I think they tackled everything, but just making sure you're wearing your mask, making sure there's safe distancing in the office or wherever you work, and making sure that you eat lunch at a safe distance, because you do have to take your mask off. I think everyone tackled all the answers.
Yeah, I think because I think the meal time or break time is probably the highest concern, because we're social people. We want to interact. This is one of the perks of being at work, is you get to see your friends and colleagues and catch up. But really, it's also a potential risk. Taking your mask off to have a sip of coffee and putting it right on is far less risky than sitting around mask off for 15 minutes or more, where you're eating and talking in a relatively closed space. So really, if possible, eat on your own. Keep your mask on as much as possible. Maintain distance. Small number of people if you have to eat in a communal location, I think is really key. There's some other questions that are related to, well, I got a J&J and then I got a Moderna. Should I wait the 6 months for the fourth dose or this third dose in that setting? What do you think, Dr. Tana?
Yeah, I guess by the CDC guidelines, that is the recommendation. The CDC is constantly updating their recommendations as more information becomes available. And just since the fewest number of people did get J&J, the data is a little slower to come out, unfortunately, for J&J. But yes, right now, the booster form would be 6 months after your second dose of Moderna.
Yeah. And then there's lots of questions about where to get your KN95s and N95s. Definitely there's lots of places where you can get them. I think that the availability of masks are a bit of a challenge. I guess that the other question that comes up, if I want to do a rapid antigen test, where do I get those?
They're available at all your local pharmacies. There should hopefully be a push to make them more widely available, but I've seen them at Walgreens, CVS. You can get them online. Sometimes they have sales, and then you know, at some places they have them available more publicly, like at public libraries and stuff. I haven't seen that in Chicago yet, but hopefully that'll come here soon too.
And then there's another question that just came in, which is a kind of a riff on what we've been hearing, but I think it's a very concrete example. So my whole family is vaccinated and boosted, and all 3 kids have gotten both doses. Is it okay to be indoors for Christmas unmasked? There'll be 11 people total. Should we wear a mask or not? What do you think, Dr. Ganger?
What do we know about the other people? But I go back to what you said some minutes ago. I think I would do the antigen test. I think if people are the loved ones in the family, they should love each other and not resist doing the test. The price has gone down, so I think that would be the safest way. Not perfect, nothing is perfect. 100%.
And then if they have to fly, should they be worried to get on a plane, Dr. Friedwald?
Yeah, it's a great question. And I think from the data we've seen that airplanes are fairly safe. And I think the reason for that, we think, is how frequently the air is turned over again. Think about COVID hanging like a bad smell in the air. If you're well ventilated, you're not going to have as much chance to breathe that in, and that's what gets you infected. So in general, being on flights is considered safe. Of course, you have to keep your mask on. I always say don't cheat, keep it on the whole time. But the bigger risk sometimes is the airport itself, whether you're sitting around and other people are eating and talking and doing what they're normally going to do. That's, again, the good news is if you keep a good mask on and try to distance from people as much as possible, you can do it safely. Again, know the ground rules, and you can't cheat. That's the tricky part. The virus doesn't care if you just want to have a quick sip of your soda. You can then breathe in the virus there. So keeping the mask on is really important. It's not fun, but it's important.
I heard the window seat is the best ventilator.
There you go. Dr. Ganger says window seat. Plus you get to look out the window.
I would agree. That's my preferred seat. Disagreement there. So Shelley, what are the most common questions you're hearing from the patients? What's on their mind from the calls you've been getting?
The common questions that the nurses are getting are definitely the holiday questions, and if they need the booster shot. Definitely get the booster. It's recommended for all of our patients, and to get the 4th booster when you qualify, when you meet the 6 months. And traveling is a big one. So we've definitely addressed it in this presentation of all the common questions we've gotten in our office.
Can I add something?
Sure.
If you're going to get your 3rd dose, call it a 3rd dose and tell the pharmacist that you're a transplant patient. The reason I say that is because the Moderna booster is half the dose of the primary series, and you guys should be getting the full dose for your 3rd shot. So I tell all my patients to say, I'm a transplant patient and I need my 3rd dose, and the pharmacist should be able to give you the appropriate dose for the immunocompromised population.
Yeah, and especially at the larger pharmacies, they've got it all programmed in. They know what to do. So this last question, and this may be one of the last ones that we get to today, is a great question. When will it end, Dr. Tana?
Gosh, I really wish soon. You know, I don't know. As long as people are unvaccinated, we're going to continue to have mutations. We're going to continue to have variants. So really, I think the key to ending this is vaccinating and getting buy-in from everyone here, but also sharing our vaccines with the rest of the world. I think at some point, hopefully, it'll get to a low enough level that it becomes like the flu, where we just get our annual vaccine. I don't know, but I really would encourage you to do your part and tell everyone you know to get vaccinated so that we can all move on with our lives.
Yeah, I think this. I personally don't think there is an end to COVID-19. I think it's here and with us forever. The difference is it's going to be much more like flu or colds, where it's not something that we're terrified of getting very sick. The best thing that you can do is getting your COVID vaccine, get boosters and additional doses as needed. I know it's frustrating to hear this. This is something Dr. Friedwald and I were talking about earlier today, is the advice keeps changing, but that's in part because the virus keeps changing. There may be more data that comes out with Omicron that says we need a new vaccine, or everyone needs a 4th dose, or we need a 4th dose sooner than 6 months. And these information are going to come out, and it's hard and challenging, and we'll continue to have these updates as new information comes out. But it is something that if we do the right thing, we'll eventually get to a point where hopefully we won't need to be wearing masks all the time. We can go to our favorite restaurant with all of our friends and not worry as much about things. It looked like you were going to say something, John.
No, I agree that the power of positive words and being a vaccine champion is really important. I think, a lot of hesitancy, a lot of people who are hesitant are just waiting to hear from the people they know and love that it's safe and recommended. And there's a lot of misinformation out there. So all we can do is try to be a force for good, saying the right things, encouraging people to do the right thing. And we know what that is. We know that the vaccines are working, and that's the way out. And as Dr. Tanna mentioned, it's not as simple as just us, it's the rest of the world too. So we're all working towards that, and we all want to get there. But we also know the ground rules, and we can't cheat and for now. And so as long as we know that, there are certain things we can do that are safe, and try to enjoy those things, being outdoors, being outside as much as you can, and hang in there. We're with you.
So with that, I think we'll just kind of summarize what we've talked a little bit about. We have the threat of the Omicron variant coming before us. But again, if we do the things that we've been doing, being careful, being vaccinated, and continue wearing our masks, we should be protected. Vaccines are incredibly effective and are the #1 way to prevent infections, hospitalization, and death. All of our SOT recipients, transplant patients, should get their 3rd dose of mRNA vaccines and a 2nd dose of a vaccine if they got J&J. You don't need any documentation or approval from the transplant team. If you've had recent rejection or transplant, talk with the transplant team about the optimal timing of your vaccine. And no antibody testing is going to be recommended before or after vaccine at this time. All of your close contacts should get their COVID-19 vaccine and booster. Now is the time. Don't wait until after Christmas. Don't wait until next week. If you're not vaccinated or not boosted, now is the time if you're eligible. Make sure that everyone in yourself as well as your close contacts get their annual flu vaccine if they haven't. You can get it at the same time. We're very close into the COVID vaccine. We're seeing cases of flu, which we didn't see last year. This is another thing we just need to protect you against. And continue wearing your masks, staying socially distanced, and avoid high-risk settings, even if you have your booster or 3rd dose. And then if you get sick, call the transplant team immediately. We can help with the testing if you need it. We will definitely help get you the appropriate therapy, including monoclonal antibodies, to help prevent getting very sick. And I'll finish with the reminder to just wear your masks. And I want to thank the group here today for their hard work, their ability to, their time to talk with you all. But more importantly, thank you all for coming and listening and doing the hard work, keeping yourself protected and advocating for your friends and family to get vaccinated.
Just a last question, a reminder, the seminar will be posted on the Transplant Village website, not immediately. It takes a little bit, but the plan is to have it posted there. Is that right, Dr. Eisen?
Correct.
Yeah, and thanks to Transplant Village, as always, for getting the word out and hosting and being great supporters.
Thank you.
Thank you. Good night.
Good night, everybody.
Good night.
Happy holidays.